Hello everyone, thanks for joining us again. Today we will talk about the Farkas system, which is the anthropometric measurement system, before going into the discussion on medical analysis more in detail, because they are very closely associated with each other. In a sense, Dr. Farkas has made a meeting point between them. Leslie Farkas created the first comprehensive craniofacial surface anthropometric atlas named as Anthropometry of the Head and Face in Medicine in 1981, and he has continued to develop new measurements and normative data through revision and updates of the atlas and published datasets. Trained in both plastic surgery and medical anthropology, Dr. Farkas created a meticulous measurement system that is based on the identification of anthropometric landmarks. Over the last 25 years, he provided extensive hands on training for clinicians and scientists in North America and around the world. This attention to detail is essential since these procedures are painstaking and careful instruction is required. The Farkas system of craniofacial anthropometry has found increasing application in medical and clinical genetics and in plastic and oral and maxillofacial surgery. Quantitative measurements have rendered the diagnosis of the dysmorphic features of both objective and reliable, a boon to geneticists and surgeons alike. Also, surgical planning has benefited from these metrics, which are useful in the assessment of the post-operative success. Both of these developments have been facilitated by the publication of the Farkas method and norms, which continue to be expanded and updated. This craniofacial surface measurement system has become a popular standard reference, providing the most extensive normative database extant for North America. This video clip provides an overview of the Professor Farkas' system of the craniofacial anthropometry and the normative database created from this methodology. Farkas' work on basic and clinical research spanning a half a century generated the most comprehensive craniofacial measurement procedures to date. These methods have provided a framework for physical anthropology research and have found its application in a variety of disciplines such as medicine, including plastic surgery and oral maxillofacial surgery, and medical and clinical genetics. Farkas's craniofacial measurement system as an alternative to subjective visual inspection is very much in the spirit of the Lord Kelvin's call for quantification. That is, I often say that when you can measure what you are speaking about and express it in numbers, you know something about it. But when you cannot measure it, when you cannot express it in numbers, your knowledge is of meager and an unsatisfactory kind. It may be the beginning of knowledge, but you have scarcely in your thoughts advanced to the state of science, whatever the matter may be. Though there had been earlier efforts to develop limited numbers of craniofacial anthropometric measurements, such as pioneering efforts of Feingold and Basselt in 1974, notably, Farkas introduced remarkable complexity and breadth in formulating his method and creating his normative databases. Leslie Farkas provided these means of quantification by formalizing object reliable means of measuring craniofacial size and shape. He adapted classical measurement techniques and created novel anthropometric procedures to produce comprehensive anthropometric atlases of human head and face. In the following, we outline his method, the compilation of his normative databases, and their use in a variety of disciplines. And finally, we will describe how his direct measurement methods are now being extended to the state-of-art digital morphometry. The first atlas of measurement, anthropometry of head and face in medicine, was published in 1981, as I said, with a revised atlas appearing in 1994. These surface measures were made with an array of direct anthropometric devices, many of them adaptation of the classical instruments such as sliding and spreading calipers, angle meters, and protractors. Additionally, he designed many instruments tailor-made for specific classes of measurement. For example, a large double sliding caliper with levers for projective measurements extending from the cranial vertex. The 1994 atlas is a compendium of projective linear measurement, arcs, angles of inclination, and deviation, each connecting anthropometric landmarks that can be reliably identified, as in the screen. Okay, at this point, let me explain some important landmarks and measurement used in Farkas system before moving on. G denotes the glabella. The definition of glabella is the most convex sagittal midline point between the eyebrows. FT denotes the frontotemporal. It means the point of concavity on each side of the forehead above the supraorbital rim, lateral to the elevation of the linea temporalis. ZY denotes zygion. The zygion is the most lateral extent of the zygomatic arch. GO denotes gonion. Gonion is the inferior aspect of the mandible at its most acute point, that is, the mandibular angle. SL denotes the sublabiale. The sublabial is the most inferior sagittal midline point of the lower cutaneous lip at the labial mental sulcus. PG denotes the pugonion. Pugonion is the most protrusive anterior sagittal midline point of the chin. GN denotes gnathion. Gnathion is the lowest median landmark on the inferior aspect of the mandible. EN denotes endocanthion. The endocanthion is the most medial point of the palpebral fissure at the inner commissure of the eye. EX denotes exocanthion. The exocanthion is the most lateral point of the palpebral fissure at the outer commissure of the eye. PS denotes palpebral superius. The palpebral superius is the most superior aspect of the palpebral fissure at the sagittal midline of the free margin of each upper eyelid. PI denotes the palpebral inferius. The palpebral inferius is the most inferior aspect of the palpebral fissure at the sagittal midline of the free margin of each lower eyelid. N denotes nasion. The nasion is the sagittal midline point of the nasal root at the nasofrontal suture. MF denotes maxillofrontal. The maxillofrontal is the lateral extent of the base of the nasal root at the junctures of the maxillofrontal and nasofrontal sutures. AL denotes alar. The alar is the most lateral extent of the alar contours. PRN denotes the pronasal. The pronasal is the most protrusive point of the nasal tip. It's known as the apex nasi and identified in lateral view. SN denotes the subnasal. The subnasal is the midpoint of the point of inflection of the columellar base at the juncture of its border with the surface of the philtrum. LS denotes labial superius. The labial superius is the sagittal midline point of the upper lip at the upper vermilion line. Li denotes the labial inferius. The labial inferius is the sagittal midline point of the lower lip at the lower vermilion line. Chalion. The chalion is the most lateral point at the labial commissure. Sa denotes the supraoreal. The supraoreal is the most superior point of the helix of the auricle. SBA denotes the suboreal. The suboreal is the most inferior point of the lobule of the auricle. With this landmark, the Farkas system utilized cranio-anthropometric measurements. Width of the head, width of forehead, skull base width, height of the calvarium, height of the head from the vertex to the nasal, height of the head from the vertex to the endocanthion, height of the head from the vertex to the subnasal, craniofacial height from the vertex to the gnathion, height of the forehead, length of the head from the glabella to the ophistocranion, circumference of the head through the glabella and ophistocranion, inclination of the anterior surface of the forehead, auricular height of the head from the vertex to porion, distance between the vertex and the tragion. In addition, there are facial anthropometric measurements used in the Farkas system as follows: width of face, width of mandible, physiognomical height of the face from the trichin to the gnathion, morphological height of the face from the nasal to the gnathion, physiognomical height of the upper face from the nasal to the stomium, height of the lower face from the subnasal to the gnathion, height of mandible, height of chin, height of the upper profile from the trichin to the pronasal, height of the lower profile from the pronasal to the gnathion, lower half of the craniofacial height from the endocanthion to the gnathion, distance between the glabella and the subnasal, supraorbital arc, maxillary arc, mandibular arc, inclination of the upper face profile, inclination of the Labial line, inclination of the lower face profile, inclination of the mandible, inclination of the chin, inclination of the general profile line, mentocervical angle, height of the mandibular ramus, depth of the supraorbital rim, depth of the upper third of the face, from nasal to the tragion, depth of the maxillary region, from the subnasal to the tragion, depth of the mandibular region, depth of the lower jaw, lateral surface half arc between the tragion and the glabella, maxillary half arcs, mandibular half arcs. Next is the orbital anthropometric measurements: intercanthal width, biocular width, length of the eye fissure, endocanthion facial midline distance, pupil facial midline distance, orbitooral distance, orbitotracheal distance, orbitogonial distance, orbitoglabella distance, height of orbit, combined height of the orbit and eyebrow, height of the eye fissure, height of the upper lid, pupil upper lid height, height of the lower lid, pupil lower lid height. Difference between the sagittal levels of upper and lower orbital rims. Difference between the sagittal levels of the endocanthion and exocanthion. Endocanthion facial midline surface distance. Inclination of the eye fissure. Inclination of the line placed over the upper and lower orbital rims. The next is the nasal anthropometric measurements. Width of nasal root. Width of the nose between the left and right ala. Width between the facial insertion point of the ala base. Width between the cutaneous labial insertion of the ala base. Width of columella. Height of nose. Length of the nasal bridge. Nasal tip protrusion. Inclination of the nasal bridge. Inclination of the columella. Inclination of the nasal tip portion. Glabellonasal angle. Nasofrontal angle. Nasal root slope angle. Nasal tip angle. Nasal alar slope angle. Nasolabial angle. Deviation of the nasal bridge. Deviation of columella. Width of the nostril floor. Thickness of the ala. Distance between the facial insertions of the ala base and subnasal. Length of the ala. Length of the columella. Depth of the nasal root. Surface length of the ala. Nostril axis inclination. Ala slope line inclination. The next is about lip. That is to say, labial anthropometric measurement. Width of philtrum. Width of mouth. Height of upper lip. Combined cutaneous and vermilion. Height of the cutaneous upper lip. Vermilion height of the upper lip. Vermilion height of the lower lip. Height of the cutaneous lower lip. Lower lip height, combined cutaneous and vermilion. Upper vermilion arc. Lower vermilion arc. Inclination of the labial fissure. Inclination of upper lip. Inclination of the lower lip. Labiomental angle. Halves of the labial fissure length. Lateral upper lip height. Labio-oral distance. Labio-outer surface distance. The final measurement is the auricular anthropometric measurements. Width of auricle. Height of tragus. Length of the auricle. Morphological width of the ear. Upper nasal-oral distance. Lower nasal-oral distance. Lower subnasal oral distance. Upper subnasal outer distance. Lower Nathian outer distance. Upper Nathian outer distance. Occipital outer distance. Upper nasal outer surface distance. Lower nasal outer surface distance. Upper subnasal outer surface distance. Lower subnasal outer surface distance. Upper Nathian outer surface distance. Lower Lathian outer surface distance. Inclination of the medial longitudinal axis of the ear from the vertical. Protrusion of the ear from the head. As you have seen until now, there are a wide variety of measurements and their combination. This network of landmarks extends across single midline structures and paired measurements. Lateral symmetry of these paired measurements are also enumerated as normative data. Additionally, in 1986, Farkas and Munno published the norms for within-subject ratios of individual measurement in anthropometrical facial proportions in medicine. The most extensive norms in Farkas atlases are for anthropometric measurement within the Caucasian North American population. Whereas the original 1981 atlas focuses on Caucasian norms, the Farkas edition in 1994 was expanded to include a broader range of subjects as well as the samples of Chinese and African American individuals. In this second edition, the norm included data for the 2,326 Caucasian North American individuals ranging in age from 1 year to adulthood. This edition of Atlas Anthropometric of Head and Face has been called a quantitative foundation for human head and face and their features of obvious value to plastic surgeons, but also for clinicians and researchers in other areas as well as others with professional interest in dimensions of head and face. The North American Caucasian norms include 132 craniofacial anthropometric measurements, with 70 single and 62 paired. Of these, 103 measurements are linear and 29 are angular, 15 cranial and 31 facial, and 21 orbital and 28 nasal, and 18 labial and 19 auricular. In recent years, Farkas and his colleagues began collecting norms for additional ethnic groups in conjunction with an international consortium of investigators. Their initial effort was published in Farkas and colleagues in 2005. Further efforts are underway to collect new normative databases outside of North America, for example in southern China. This painstaking anthropometric measurement technique requires extensive training in order to be performed reliably. Autodidacts who have learned merely from written method often find after training that many of their original measurements have substantial errors. The standard deviations for many population measurements are small, and minor measurement inaccuracies can translate into large errors in standardized scores. Take, for example, variability seen in measurements of the width of the head, the linear distance between the urion, the most lateral extent of the cranium. For school-aged children of both genders, standard deviations for head width range between 4.2 and 6.3 mm. During the studies at the Craniofacial Center of Children's Hospital in Boston, they have trained many surgeons to perform Farkas-based measurement protocols. For those surgeons who already have some familiarity with the Farkas Atlas, but not hands-on training, they conducted a pretest to document their measurement before giving instruction and then went on to provide formal training. After the surgeon had been trained, they repeated these measurements on the same subjects seen earlier. A comparison of the pre- and post-test revealed that their measurements of the head widths in particular were frequently off by several millimeters. Thus, it was not unusual for the standardized score to be in error for this measurement by a full SD or more. In contrast, after training, the surgeons and other extensively trained examiners typically have achieved the test, retest, and inter-rater reliability coefficient over 0.90. More recently, these have been extended to include digital measurements using the Farkas system. Dr. Farkas and his trainee have extended instruction to a network of investigators and clinicians. There is also a video instruction to the anthropometric landmarking system with a discussion of direct measurement and 3D surface imaging. However, it provides only a brief initiation and does not provide the requisite training for the Farkas method. Also, a complementary description of the anthropometric procedure has been published by Caroline Salter in 1993. As the means of the 3D digital surface acquisition have become available, for example, laser scanning and stereophotogrammetry, there have been increasing interest in clinical research community for image analytic techniques. One clear advantage of using surface image is that they provide a resolute data set for storage, thus allowing subsequent morphometry. This provides an opportunity to clinicians and investigators for ad libitum post-acquisition measurement. Another advantage of using digital surface scans is that they permit image acquisition of young children and developmentally disabled individuals who sometimes cannot sit still for long for a direct anthropometric examination. Some of the 3D imaging devices that became commercially available in the 1990s could capture an image in a matter of seconds, but rapid as this period was long enough to introduce motion artifacts. Fortunately, later advances in alternative imaging techniques, for example 3D stereophotogrammetry, permit image capture in less than 2 milliseconds. With this rapid acquisition, image distortion no longer a problem. Morphometry can be performed directly on 3D images. The point cloud generated by the imaging system is plotted in space, and XYZ coordinates are computed for the scanned surface. 3D stereophotogrammetry measurements are resolute and reliable. In order to utilize the Farkas direct anthropometry norms, it is important to provide validation of direct against digital measurements. Indeed, in a study of the metric quality of the 3D MD stereophotogrammetry imaging device, the majority of measurement via direct anthropometry and image analysis by trained rater were highly correlated. Efforts are now underway to make available the Farkas norms in electronic format to the clinical and research community. These norms have recently been structured within a digital database, FaceValue, created with the support of the U.S. National Institute of the Dental and Craniofacial Research. This will provide the clinical and research community streamlined access to the norms and the opportunity to readily compute the standardized scores conditioned on demographics. The objective is to make the Farkas norms more user-friendly by creating a computer-based interactive craniofacial measurement database for them. The software is designed to facilitate ready access to lookup tables conditioned on patient demographics using a menu-driven landmarking-based interface, and permit computation of the standardized measures for the patient, including user-created functions, and generate reports for the anthropometric protocols conditioned on the professional specialization, and finally, export derived scores to database for documentation and statistical analysis. In addition to being a medical anthropologist and dysmorphologist, Dr. Farkas was a plastic surgeon. His anthropometric methods were designed to accommodate the craniofacial surgeon in pre-surgical planning and post-surgical evaluation. As Dr. Paul Tessier wrote, it is first necessary to determine for the patient what is ortho and what is this. The Dr. Farkas system permits the surgeon to establish concretely the degree and type of abnormality using his toolbox of measurement. Anthropometric workups have proven helpful in planning surgical procedures and evaluating outcomes for a number of conditions including cleft lip and palate and craniosynostosis. For example, in unilateral coronal synostosis, employ the anthropometric analysis to compare the outcome of two contrasting surgical techniques in the correction of the dysmorphology. Further, O and colleague in 2008 used the Farkas procedures to study the long-term outcome of the unilateral coronal synostosis patients who had fronto-orbital advancement surgery in infancy. They determined that even with surgical intervention, these patients displayed the residual, consistent middle and lower facial asymmetry. The Farkas quantitative measurement provides the metrics for designing the type and degree of planned surgical alterations, and it can be useful to combine these measurements with complementary imaging techniques. For example, instantiation of the craniofacial surface images and their landmarks to radiographic CT and MRI-based images will delineate the relationship between the facial surface and the underlying tissue. This multimodal approach can be useful in designing surgical interventions, as seen in examples drawn from the clinical workup by the Labial and his collaborators at Surgical Planning Laboratory at Brigham and Women's Hospital in Boston, Massachusetts. They merge the craniofacial surface image acquired by the cyberware laser scanner with both 3D CT and MRI data for case study of patients with Crouzon syndrome. This autosomal dominant genetic condition, a form of craniofacial dysostosis, is characterized in part by orbital hypothyroidism, an abnormally large distance between the eyes. A 3D digital template was then constructed and used to estimate the optimal parameters for repositioning the patient orbits more medially. The response of soft tissue to the changes in the underlying bony architecture is still not well understood. Quantitative measures of its morphology can also be used to examine early developmental factors. It is possible to study anomaly combination chosen to indicate specific developmental classes of dysmorphogenesis. These include the chronological origin of dysmorphogenesis, the mechanism of alteration and embryonic primordia, and from which dysmorphic features arise. By the 19th day of the embryonic development, the germ layers and their subdivisions have formed into recognizable discrete masses, and craniofacial differentiation first appears within this anagen. Quantitative tests of these brain-face relationships are made possible by anthropometric method. One example is the correlation of craniofacial asymmetry defined by the Farkas measurement and brain midline maldevelopment predicted by fate maps. The Farkas methods have also been used to geneticists in the diagnosis of craniofacial dysmorphology. With the aid of the Farkas atlases and normative databases, it had been possible to create a protocol permitting objective, reliable assessment of the dysmorphic features. Here, craniofacial anomalies can be measured as standardized scores conditioned on demographics. Importantly, they are quantified on a graded continuum that spans from normalcy to minor anomalies to major dysmorphic features. A common challenge to geneticists is the problem of heterogeneity with respect to both etiology and phenotype, and this holds true for many complex disease states. This problem is particularly challenging in the field of neuropsychiatric disorders, for example, autistic disorders, which have a statistical overrepresentation of the craniofacial anomalies. Here, two approaches utilizing quantitative dysmorphic phenotypes can be used to come to grips with heterogeneity. Collections of anomalies across patients can be cluster analyzed to determine whether they cohere. The Farkas system measurement have been used to study several craniofacial disorders, including Apert, Crouzon, Down, and Tricho-Collins syndromes. It is noteworthy that application of this method to the study of these syndromes not only validated prevailing clinical opinion on the occurrence of specific anomalies, but also identified dysmorphic features that had gone hitherto unidentified. There is also potential for broad use in biometrics and bioinformatics. This has not yet been fully realized, perhaps because an electronic version of the Farkas databases has not been widely available. The distribution of the normative data in a digital format will hopefully make the databases more tractable to ID-based analysis. Anthropometric methods have also been applied to a variety of other fields, including industrial fabrications. They have been used in modeling of helmets or goggles on a tailor-made basis that conform to the individual. Further, the Farkas method have also been used in a tool in forensics. One example is the application of the facial morphology measure on a developmental continuum to age photographs. That is, a photograph of child can be measured and morphed using existing norms to estimate facial appearance with advancing age. Farkas was an early adopter of aging algorithms that have aided search efforts for missing children. Now, I'm gonna summarize today's lecture. The Farkas anthropometric methodology permits objective, reliable quantification of craniofacial morphology. The anthropometric examination is painstaking and requires training. The Farkas normative databases allow computation of standardized scores based on age, gender, and ethnicity-specific characteristics. These methods permit quantitative assessment of this morphology on continuum and are commonly used for individual case studies, delineation of patterns of anomalies in heterogeneous patient groups, and in the description of the distinctive facial appearance in identified craniofacial syndromes. The Farkas methodology is also a useful adjunct in craniofacial surgical planning and assessment. These procedures also are useful in population-based physical anthropology research, forensics, and biometrics. Advances in 3D craniofacial surface imaging are permitting rapid image capture, which can then be analyzed using Farkas system-based computer-aided morphometry. Okay, this is the end of today's lecture. Thank you for listening.